My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy.
And you're listening to the Fix Podcast.
So here's a great case. Actually my associate sent me this picture and he was like, "Hey, I need some help," right? He's like, "This patient can only afford to do the upper." And really, his lower teeth aren't that bad. Now we always do need to remember that sometimes the patient needs to be a bijaw. Also don't forget about orthognathic surgery. We can definitely, always do that as well. But how do you do orthognathic surgery when the patient only has like 5 teeth, right? So just because you can doesn't mean that you could. So or just because there's a treatment option out doesn't mean that it's practical or available. So how do you manage this, right? So let's go to the next slide. So, here we can tell we've got the full facial profile view and we have the side facial profile view. And we can really tell his maxilla is super deficient, really collapsed, right? So, okay, well, how do we do this? We need to be looking at emergence profile. Are we going to just mow down a bunch of bone to then, kind of get that gap? But then how do you deal with, is it going to create a big diving board? Is it going to protrude the lip too much? And so, one of the easier ways to gain restorative space is open up the bite.
Yeah. And that's going to decrease that class 3 characteristic as well as you do that.
Totally. Yep. So let's look at the next slide here. And so that's what I did. I said, okay, well, let's all it takes is a little bit of flowable composite. Generally for most patients, when you want to open them up, as long as they're not class 3, you can just put it on the mandibular central incisors and just cure it, have them close down, look at it, add some more, open them up to where, they feel good. And generally I'll ask them, how does your jaw feel? How do your muscles feel? And, when these patients are actually over closed, they'll wind up telling you, hey, my jaw actually feels better. My muscles actually feel better. Other avenues that you can do, you can use a leaf gauge to do this. I don't recommend that because how then do you evaluate the patient's facial profile? It's very hard to evaluate that with this big piece of plastic sticking out of their mouth. So on this particular gentleman's case, he had very few teeth to actually occlude on. So I had to kind of put it back on his molars bilaterally to kind of open him up. Let's go to the next slide and then we'll probably come back. Oh no, we didn't get the
I didn't have any photos then. Yeah.
We're missing some photos, but let's go back. As we evaluate the patient, we're then going to look at their overall facial profile. And so this particular patient actually wound up his facial profile looked better once we opened him up. Wow. And so, he looked at himself in the mirror and said, yes, I really like that. Now my lower third of the face is matching the middle and the upper third. And he was very happy. On cases like that, I know a lot of people like to just do all digital. I really think that for skeletal malocclusions, it is really nice to have a physical model. And for you to mount that on an articulator and evaluate it. That way, you can look at it in your hand. And then if you want to go ahead and scan, you could scan the articulator. I would take an intraoral scan of the patient, just as he is. And then you could scan the stone models. But you can't do things 100% digital, and you can't do things 100% analog. It's always got to be a good blend, and you need to be able to know when to kind of pivot to those.
For
And
sure.
I think that these really big skeletal classifications or skeletal malocclusions articulate it, get the stone models in your hand. You are going to then know where to tell your lab colleagues to set the teeth.
Yeah.
And so, obviously here, really kind of jumping that bite and getting those teeth into a normal class 1 occlusion is not really going to be that difficult. His maxillary lip and his maxilla is already deficient, so we know we need to add anyways. So here, if we literally add 2 millimeters buccal to this guy's face and lip, it's going to look outstanding, and then that's going to get us back into a normal class 1 occlusion.
Yeah.
So
Yeah,
really good learning there.
Yeah, I'm impressed because with just that initial photo, I'd be convinced that you were going to be turning this into a bi-jaw surgery to help jump that gap, because it's quite efficiency.
Yeah. And so, if you didn't open the patient up, I think you're putting a young guy in, teeth are always better. Like that's
You bet.
what
Yeah.
everybody really needs to know is that, teeth are always better than implants. And so at least we give them a fighting chance, on the lower to kind of keep those teeth, longer term. If you look really closely, I definitely told this patient, hey, I want you to plan for, we need to raise the posterior occlusion on your right side. So plan for crowns on 28, 29, and 30. And then, maybe we'll kind of level out, kind of that 23 and kind of 22 area.
Yeah.
But once we actually open them up, it doesn't look, the lower occlusion doesn't look as canted.
Yeah. Which is odd. Yeah.
So lot of fun. I mean, these are so many things that I learned how to do just doing analog pre-prosthetic planning with a wax
Right.
rim, right?
Yeah. Yeah.
Hey, let's do a wax rim. Let's kind of play around with opening the bite, and you can achieve the same thing with just some flowable composite.
Yeah. That's awesome. Very cool.
So here's another fun case that presented to our clinic here, and just so many things. I mean, Tyler, I've talked for a while here. Why don't you kind of give us your
Yeah.
thoughts?
Yeah, it seems like they skipped a step. So we got a whole lot of maxillary bone. We almost have the distal aspect of the tuberosity occluding on the retromolar pad. So just a whole lot of excess bone there. You got an implant that's right abutted up against the terminal tooth that was left for, whatever reason. Not much of an serviceable occlusion on the lower, and this might be just a factor of the reconstruction of the Pano, but there's not a whole lot to work against with the lower either. Definitely could have gotten a much better spread. I mean, there was just a mile of bone distal to your tilted implants.
Yeah.
And we're obviously missing pterygoids. I know we're in the same camp on that. So there's probably a whole lot more going on outside of the radiograph, but I see enough to warrant a revision.
This would be a case that may not even actually need pterygoids. You could probably give this patient
That's true.
6 implants. I mean, that maxillary sinus, you could get after you do an adequate alveolectomy, you could wind up with a posterior tilted implant in the second molar position.
Yeah.
Then
you could.
I mean, this is one of those random cases. We don't ever see these, right?
Yeah.
But if that was in the office, you go all the way back to the second molar, and then I'd probably put an implant in the canine, and then I'd put an implant in kind of that lateral position.
Yeah, I still think a 6 implant configuration would be really nice, but you're right. You're probably not going to need a pterygoid here, depending on the smile line, of course. But just where that anterior sinus border is, it's very distal. So yeah, you should be able to get away with getting your tilted to the second molar. That's great. Yeah.
But you know what generally happens is when you think you can do a second molar implant tilted, you can't because the bone is just terrible.
Oh,
You know,
yes.
even
before.
even
Yeah.
even if you get to the, lateral nasal wall, you may not even get there, but generally that bone is just going to be pretty awful. So,
Yeah.
oftentimes I would never plan or hope for that, because
Sure.
generally it's just going to be mush. It's going to be yellow bone.
Yeah. 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 Fatty.
All right. So I think the next slide, what do we have on the next slide here? Next slide is basically how I would have approached the case. I mean, just from a general overall, whatever, getting the alveo, getting the restorative space there.
Yeah.
So,
Absolutely.
taking out that terminal tooth, a patient like this, they need at least a lower flipper, like let's give them, some type of a balanced occlusion, to
Right.
help, I mean, I still will do, some analog surgeries. And if I'm going to do an analog surgery, I want a nice flipper made to the new upper teeth so that I can really lock in that bite.
Yeah. Absolutely. Oh. Yeah.
Yeah.
That's
So
pretty
here we go. This is just an absolute shit show. I mean, I think on the Texas Implant Institute Instagram, I said that, this is what happens when you force a case to be a standard.
Yeah.
And this is truly a patsy case. If you look at that, subantral posterior bone, it's like 3 to 4 millimeters until you get to the sinus. And that should have been a zygomatic. We should have had, pterygoids bilaterally. And we didn't need to penetrate into the maxillary sinus like that.
Do you think that there was an attempt here at a Trans-Sinus implant?
Well, they're not
Am I giving it
angled
too much
enough.
credit? Yeah. I might be giving it a little bit too much credit. Yeah, it's almost axial, just going into 3 millimeters of crestal bone, and then you probably got a good 12 to 15 just hanging out here. It's a pretty long implant, to their credit. They
I
thought that
mean,
was
maybe they were aiming for the middle meatus.
yeah, maybe. Just didn't
There's
quite
not
get
much there's not much bone there.
there. No. No, there's
People are crazy, I
Yeah.
don't know why. Again, it's just seeing if you can only, this is why you have to do more courses. This is why you have to have a tribe. Like what is truly amazing is if you live in Texas or Oklahoma, you can have me come into your office. I can come in and I can do
Right.
advanced cases for you. Juan
Yeah.
can, Dan Holtzclaw can. There's multiple people that you can reach out to. But here's the deal, if you try to be too greedy, and if you try to keep the case yourself, it's like, I don't want to say the M word, but I mean, this is less than ideal. I mean, it's definitely not the
Yeah.
standard of care. If you go into the next slide, I think that, we can see the implant is 9 millimeters into the maxillary sinus.
Yeah.
And the middle one is 7 millimeters into the maxillary sinus. I mean,
see.
luckily enough for this patient, the implant's stable, and he doesn't have there's not any sinus pathology there. So, kind of dodged a bullet. One thing, if you look at the lower pano there, or the lower implants, do you see how buccal those are? It's really kind of putting quite a bit of pressure on that anterior buccal bone on that
Mhm.
mandible. So
Yeah, and it actually looked a little bit curious right through here on the Pano as well.
Yeah,
Curious about how that buccal bone's done.
I don't know where that cross section was taken. I guess it would have been on that particular implant. Yeah, it does look like that is an ailing mandibular implant. But, just take people up. If you don't want to refer out the case, refer in. Refer
Bring
in
'em
a
in.
provider, I mean, I'll come, I think I charge $5,000 an arch. I can come into somebody's office. You get to keep the production. Let's just get an anesthesiologist, and then you can sit there and learn. Okay, well, this is how, Patsy's done.
Right. And I think there's a lot of people that, if they just had the guidance of you need to go here instead of here, they'd be able to accomplish the case. It's just about having that sort of guiding person over your shoulder, say, hey, let's do this instead of that. And you might be able to pull off the case in a beautiful fashion. Just if you, go through that extra step, it is bringing somebody into the office. And then, you can still make money on it, still make profit, and you've made an education course out of a case. It's a very doable thing.
Yeah, you get
really,
free education that way.
Yeah, your patient almost pays for it in a way,
Totally.
Yeah. Oh yeah.
So this case definitely rocked a lot of people in the Texas Implant Institute chat.
Yeah, for sure. I can see why.
So, there's a lot of talk about FP1 right now. I don't see Juan doing FP1. I don't see, Dan Holtzclaw doing FP1. I don't see David Zelig doing FP1, right? So, I'm in some other chats with some amazing worldwide clinicians, and I said, hey, can somebody give me some articles on the success rate of FP1? And it was total crickets.
Yeah.
There's not really very good long-term studies. So, when I first saw this patient, I was like, does this guy really need a fixed arch? Like, do we really need to do this? Why don't we just give this guy some veneers or something, right? But when you really get into it, I mean, he's got interproximal decay, cervical decay everywhere, and just his gums are inflamed. And so you just go down this triad of like, okay, well, buddy, do you want trying to maintain these teeth, and do you want $60,000 worth of crown and bridge that you may or may not be able to take care of? And he was just like, absolutely not. I can't see myself doing that. And so, I think this particular patient was 35. And I tell all of my patients who are really kind of under like 55, how long do you think this will last? And what's really surprising is most of them are like, hey, if I can get 15 years out of this, I'll be super happy, right? Now,
Yeah.
I'm not about here to say that I want my cases to only last 15, right? I would be very upset if my 3,200 arches only last 15 years, right? Like I am into the golly, how many years have I been doing this? 15 years. So I am seeing my cases from 15 years ago, and they are still looking really, really good. Where I have a problem with FP1 is if you look at the older articles talking about what is the difference between alveolar bone and basal bone. Tyler, do you know the difference?
Alveolar bone and basal bone?
Yeah.
Basal bone's harder. I get more torque out of it. I don't know. Something like that.
Well, so it's actually embryological.
Okay.
So alveolar bone is actually formed with the tooth. Basal bone is not formed with the tooth.
Okay.
So when the tooth is pulled, what goes away? Alveolar bone.
Alveolar bone. Yeah, naturally. Yeah.
So I learned a long time ago, seeing fixed cases with just present to clinic. And I'm like, hey, I can already see, we didn't even do surgery, just through the mucosa, we've got 5 millimeters of thread exposure, right? Like, how did that happen? they weren't in a denture. They weren't in a denture that rubbed against it. They were in a locked in fixed prosthesis. But when you begin to start looking and you look at the height at where the fixtures were placed, they were all placed basically, maybe 2 to 3 millimeters below the crest at the time of tooth extraction, and no or very little alveolar bone was ever reduced.
Right.
So that's where I have a big problem with FP1. Where I don't have a problem with it is if you socket shield where every single one of your implants are, and if you root bank every tooth. Okay. So if you do that, I'll be perfectly happy. Why? Because if you keep
There's something maintained the
if
tooth.
you keep the tooth, you keep the alveolar bone, right? So all that stays with the periodontal ligament and the tooth. That all supports each other. So so that's kind of my philosophy, and realistically, I think a lot of FP1 cases could actually be veneer patients.
Could be veneer patients. Yes. Yeah.
Yeah.
I can see that. Yeah. They're definitely. Yeah. Yeah.
So anyways, we gave this guy what he wanted, and that's the other thing too, is you can't just judge a doctor, by the picture. I mean, look at Michael Appa, right?
Yeah.
Like if you were to judge his cases that they do veneers on, you're like, golly, they had great teeth to start with, right? Like that they didn't need to be prepped. Those teeth didn't even need to be touched, right? So how is that any different?
Mhm.
Right? Okay. So just certain things to think about. It all comes down to, what did you talk about with the patient? What were the patient's goals? What did they have in mind? Right. So just, you can't just sit there and criticize somebody, right? Like, I mean, veneers, the orthodontist always tell the veneer docs, like, hey, you could have just done braces and kept their teeth all together and whatnot. I mean, I'd have a pretty hard time rolling around with braces again at 42.
Yeah.
I'd probably rather go down to Smile, Texas and get veneers. But so it's the same. It's the same thing, right? So we had a discussion with the patient, give him their options. He's like, no, I'm done. Now, this particular patient has so many red flags, right? So Tyler, so what are the red flags that you see on this particular patient?
Well, glaring to me is a super, super high smile line that's above sinuses that are all the way pneumatized down. I mean, that's like, yeah, that's right in front of my face. That's a really obvious one. Other than that, just, I mean, really, really poor OHI. I don't really care too much about an open anterior bite if I know I'm going to do FP3 or something like that. But I think, having to deal with the sinus is the number one thing that I'd be concerned about. Because I know this is going to have to be a crush or something like that in order to hide my prosthesis.
Sure. But when a patient has a anterior open bite, you need to evaluate them for being over too far open. So,
okay.
So we
Sure.
need to evaluate the patient's overall facial profile. And so here he is way over opened.
Mhm.
So we're actually going to close this patient down.
Yeah.
Okay. And that is going to help with everything. So, but yeah, sinuses touching the canines, red flag. It's only a red flag because you need to be able to execute on a Trans-Sinus, right? The guy that's done 3,200 fixed arches, I have about a 70% success rate with Trans-Sinus. So that means 30% of the time we're going to need to do a zygomatic.
Zygo instead. Yeah. Yeah.
So, but yeah, this guy's sinus is below the reduction plane. We can see the mucogingival junction. So he has a high smile line, low sinus, anterior open bite, excessive VDO, right? So he's got a bunch of factors that we have to compete with.
Yeah.
So let's see what's on the next slide.
Wow.
All right. Okay, so there he is, and I couldn't get him to smile more than that. But
Yeah.
look at that. Like if you were to preoperatively evaluate how far the maxillary incisal edge is from the lip, that's about 10, maybe 7 millimeters, right? And so now these are his surgery temps, right? These aren't his finals. We're actually currently in his final making stage, and we do a 3-step all digital final workflow. I like
Yeah.
to let them heal for 3 to 4 months.
Sure.
Tissue always changes, and you know me, we are thinning the flaps. We're doing
Yeah, of course.
everything we can. So, I mean, he looks great, right?
Yeah.
Let's
Different
see
person.
let's see if I gave you his Pano.
He even trimmed the beard a little bit. I appreciate it.
Yeah, he's starting to look a little better.
Yeah.
And there he is, right? So look at that. So we readjusted his entire occlusal plane. We spent a long time scoring around his sinus and doing an entire sinus crush bilaterally. His sinuses are actually really nice, good, free and clear, and we were able to execute on his bilateral Trans-Sinus.
Yeah,
So,
it's really nice. He's got this sort of the way the sinus kicks back for you was conducive to
yes,
being able to do that Trans-Sinus. It's really nice. Yeah.
yes. I would not necessarily want to have to do a zygomatic implant on a sinus crush case.
Yeah. I can see how that would be harrowing.
That would be tough. So what I would prefer would be maybe, let's assume I wasn't able to nail the Trans-Sinus. Maybe bring it from the kind of first premolar position bilaterally to the canine, let
Mhm.
all of that heal, and I'd probably let it heal for a good year, and then I would roll back in and do zygos bilaterally only after the alveolus and the basal bone is really kind of reformed and refused.
I can see. Okay. Okay. That makes sense.
So,
Wow.
so the advantage to a sinus. Now, your other option to do this case is you could preoperatively do bilateral sinus lifting.
Yeah. And then you can mow it down to where you need it.
And then you can mow it down to where you need it.
Okay.
Yep.
And why did you opt for the sinus crush instead? Just because it's a single stage?
Single stage.
Perfect. I think some people will probably be very, I'm impressed as well. So the right pterygoid right here, very little tuberosity. I get asked about this a lot. If you just don't have a whole lot of tuberosity right here, is a pterygoid still doable? Well, there's always, doing a Trans-Sinus pterygoid, of course, right?
Yeah, so that
At least
that
that's what I
case actually turned out to be really cool because as we infractured the sinus, uh I was able to get that small tuberosity bone to actually kind of crush a little more anteriorly.
want.
And so it actually was not a Trans-Sinus pterygoid. So
Cool.
it actually
Wow.
worked really well.
Very cool. And can we kind of like, we don't have a picture in here. And you described it before in a previous episode, but what does the scoring of the tuberosity and the sinus and everything look like prior to crushing it?
So you need to score it 360 degrees, especially on the palate. So
Yeah.
that palatal bone is really dense, and you need to score that, or else you can't get mobility of your
Yeah.
crutch.
Yeah. Okay. Okay. So it's like a 360, and then do you kind of hash it throughout to kind of help it buckle in a little bit when you crush it, or
No, well, I'll just begin to just
it's a
tap
circle?
with the back end of the osteotome.
Cool. Very, very cool.
So it's like, the only Norris product I've purchased is their osteotomes, and I'll use the larger osteotome and hit it, in reverse.
Okay. Very nice.
Hit the blunt end of the osteotome with the hammer so that the rounder handle portion goes in.
Yes, that makes sense.
Yes. So here is so anyways, case worked out beautiful. It's that particular case was a lot of ifs, and it's like
Yeah.
a lot of things really kind of have to work, and then if you start tipping the scales, it's catastrophic ultimately.
Yeah, that's for sure. Yeah, that was definitely an ambitious case.
So here we are. We've I don't know, Tyler. I'll let you take this questions or whatever you got.
Yeah. So so just questions about this slide.
Yeah.
Yeah. So, I mean, it looks like, we've done this. I mean, it's very similar to the first one we saw, right? So we've done a vascularized interpositional, pedicle with the CT here. We've got a transosseous suture to fixate it anteriorly. And it looks like, I'm trying to tell, I mean,
It looks
is
like
this
we punched through the connective tissue. I think it was a very wide,
really wide and thick?
uh,
Yeah.
very wide, very thick. And if you notice on the anterior fixation transosseous kind of suture there, I actually wound up wrapping it once or twice. So sometimes
Okay.
you can go through these more
Just go through
and
the
then
same hole.
go through the same hole several times, and it
Oh,
just
cool.
gets it really, really
Oh,
nice
that's smart.
bound down.
Yeah. Nice. I've done that sometimes on the low. I've never gone through it with the same suture, but sometimes I'll use the same hole for two separate sutures to kind of like bring tissue in
Sure.
or something like that. I've never run it through 2 times. It's really smart. I've never thought
Yeah.
about that.
Yeah.
Very nice.
And I like using 2O chromic.
Yeah.
Now
We've implemented that as well. It's like a rope. It's great.
it is a game changer,
Yeah.
I mean, you can get the same size needle. You may just have to go to a different supplier. I don't know if Henry Schein has the
Yeah.
bigger circles, but you can just reach so much deeper with these bigger sutures, and
Yeah.
you can pull harder. I mean, my sutures aren't ripping intraoperatively anymore.
Right.
The 2O is an absolute game changer.
Yeah. Yeah. Highly recommend that for sure. Cool. So what I'm curious, and for those that are just listening in, the question here that while we're discussing this is to use the Buccal Fat Pad or to do a scarf graft. So clearly you did not use the Buccal Fat Pad here. How do you is it really just an evaluation of the connective tissue that you have to work with? And if it's adequate, that's what you're going to do. Is that really the decision point there? Or is there anything else?
Yeah, if you're unsuccessful or do not like the connective tissue, if it just wasn't thick enough, you weren't able to get it where you needed to go, and if you had like a overtly buccalized zygoma,
Yeah.
then we would roll to a Buccal Fat Pad.
Okay. And
But again, I like saving the Buccal Fat Pad for rainy days.
Of course. Yeah, absolutely. Absolutely. Yeah. I think what you said earlier about doing a scarf graft or doing anything with a CT, that's going to be regenerative, right? So but you use the BFP, you're probably going to get that one time, maybe twice.
Yes. Yeah.
And I'm noticing too here, one thing I've been thinking about recently is, I've been thinning my tissue for probably a little over a year now, because of your teaching. But I was curious about how much thickness do I actually need to leave on that palatal tissue? And I can see here it's maybe a millimeter of thickness of tissue, right?
I would say it's at least 2. It's at least
2.
2.
Okay. Harder to tell with a photo, but yeah. Okay.
Whenever you can tell whenever it's too thin, there's not any. It's just yellow, and
yeah.
so at that point you've really taken all of the blood vasculature out of that tissue, and that can lead to some palatal necrosis postoperatively.
Yeah. Yeah. That would not be ideal. Okay. Very good. And I like how, you teach everybody to go very deep with this as well. Like it's like the whole depth of like your 15 blade, like you've really thinned it, very far in that. I'm not really even sure how to call that dimension. But it's a very wide graph that you're separated
Yeah,
out
so
there.
it's not just the depth of the blade.
Mhm.
Generally, I would say that the depth of the cut is at least 2 blades tall.
Mhm. Yeah.
Yeah, so kinda like what you said, like, you're gonna take it all the way down to, like, that shank where the
Exactly.
15 blade widens out.
Yeah, not just the cutting portion, but the whole, like, you're going down to the shank there. Yeah.
Yes.
That's what I've been doing recently.
Now,
Helps a lot.
you are gonna get bleeders,
Oh,
uh,
yeah. Yeah.
but that is not a contraindication, right?
Yeah.
Like, so
Yeah.
the benefits of thinning far outweigh just the little, uh
Nuisances of
nuisances
blood. Yeah. Yeah.
of like a blood. So, and I'm surprised. I'm always shocked at how many people do not have even just like a simple electric artery device. It's
Mhm. Yeah.
$800
Yeah. It's easy.
and it works really well. If your electric artery goes down, you can just run suture off your bleeders. That is definitely another option.
Mhm. Yeah. Yeah, that's really good. Yeah, I mean, I just know how to handle a bleed, right? I mean, that's just
Yeah.
one of us. Yeah,
So
absolutely.
so 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 thinning the palate allows us to have more restorative space.
Yes.
A It's actually going to give us a stronger prosthesis because we're not going to have these little chimneys of zirconia
Yeah.
that go in. I mean, like we've all seen, our zirconia break from time to time. And, to be honest, I'm actually shocked when it does because I'm like, golly, that's actually fairly thick. I'm actually surprised that broke.
Yeah.
And then I think back to all these Instagram posts I see with these like little bitty thin, like zirconia little chimneys, going
Yeah.
transmucosal, right?
Yeah.
So increased restorative space, a stronger, thicker, longer lasting prosthesis. We are able to then advance our keratinized gingiva buccal to our implants, right? And then,
Mhm.
again, it's like riding the bike. If you ride your bike every day, you're going to be really good at it. If you don't, you're not. And so then this allows to really kind of buccalize, kind of like a VIPCT, and it's there when we need it.
Yeah, and you're used to doing that,
Yep.
every time. I definitely think with, you're talking about those chimneys and that's a big thing. And I think if you're doing, direct to multi-unit, especially with a printed prosthesis or zirconia, whatever it may be, no material aside from titanium is going to really tolerate that such a thin little protuberance that's going away from the intaglio of your bridge, going transmucosally. I can't tell you how many times I've seen like another provider's prosthesis that's been in the mouth for a couple of years, and you take that out, it's chipped almost every
Yeah.
time. It's chipped at
Yeah.
that interface. It's super common. Zirconia that does not zirconia doesn't do well when it's thin. It's very brittle. It's a very brittle
Totally.
material, and so
You know,
thinning out that palate is huge. Getting it embedded in the intaglio.
what's stronger than titanium is cobalt chromium.
Yeah, sure.
So
Yeah.
Zircon's on has a cobalt chromium product, and so on
Mhm.
occasion, uh, we've milled out a cobalt chromium,
Brilliant.
kind of bar,
Yeah.
because super strong, way stronger than titanium.
Very nice. And is it still? Does it have some malleability? Can it bend a little bit, or is it more prone to fracture?
No, it's I don't know. We'd have to pull out the engineering deals
Yeah.
on all of that, but I would
We'll keep our doctor hats on.
yeah.
That's fine with me. But yeah, that's a great idea, especially if someone's. I've actually heard of people fracturing tie bars, which is amazing. But there's certainly indications. Okay.
So, let's, kind of talking about, the Buccal Fat Pad. Um, it's, in dental school, our oral surgery colleagues, talked about, or even just lay people. They think, oh, well, it's going to change my face, right?
Mhm.
So there's actually, several different lobes of the buccal fat. And so
Yeah.
I do not want to go into that. I do not go through the buccinator muscle, which is where you can actually pull the buccal lobe of the buccal fat. Also, you're actually kind of close to, Stenson's duct, the parotid, and so
Mhm.
I stay. I don't go there. I actually pull the buccal fat out of the infratemporal fossa, right? So just kind of right there back, right by the pterygoid. We'll just kind of
Yeah.
go through the periosteum there, and then just it's just sitting back there waiting to be pulled.
Yeah.
But the buccal fat has its own blood supply, and so it's got like the deep temporal. It's got the buccal artery, portions of the PSA. There's some maxillary artery branches that go into the different lobes. So it's a living capsule as long as you don't detach it, and as long as it's
Engine.
not super thin. You
Yeah.
need to really kind of pull the whole big capsule.
Yeah.
Uh, how we approach getting it, and probably if you guys will check out the Texas Implant Institute YouTube page, I actually took a video of me harvesting the buccal fat
Cool.
a couple days ago. I'll post that, and I'll put it on our Texas Implant Institute WhatsApp.
Yeah, for
Uh,
sure.
and I saw a guy on Instagram yesterday, this morning, I don't know, in the past 24 hours, 48 hours. He was using a 15 blade
Oh,
to
yeah.
to go back in there, and I was just
Blunt
like,
dissection, buddy. Blunt dissection.
blunt dissection. So
Yes.
take a pair of sharp Dean scissors and punch it in, and then spread those scissors as wide as you can, and as you
Yeah.
open it up, you're just going to see that yellow gold back there,
Mhm.
and you really get one good spread with your scissors to really kind of open that up. And then beyond that, sometimes I'll actually use the beaver tail end of my periosteal to really
Mhm.
kind of
Tease it.
tease it tease it out and pull it. Let's see what I have on the next slide here.
Yeah. There we go.
Yeah, so there's kind of the different the different lobes, right? So different people describe them differently. They'll kind of talk about it 3 lobes. Some people quote that there's 4 lobes, right?
Mhm.
Like but generally there's the buccal, the pterygoid, the pterygopalatine, and then the temporal. So the purpose of the buccal fat is really so that all of our muscles of mastication can kind of slide against each other.
Lubricating, yeah.
Lubricating it. Yep, there you go. But again, we're gonna pull it from the fossa, and so it's not the temporal, it's not the buccal. So it'll either be generally, I think it's what we're pulling is this pterygoid lobe. The pterygopalatine, you're not gonna really try to pull that lobe. That's deep. That's pretty deep
Yeah.
and pretty high up, right up against the pterygopalatine fossa, which that's also where the maxillary artery enters into the maxilla. So
Yeah.
obviously stay away from that. In one of my cadaver labs, and I'm going to start doing this at every cadaver course. Whenever we're done, I want to do a study where we're going to measure the relationship of the maxillary artery to the probably just like the tuberosity. So
Mhm.
there's actually kind of very few studies that have kind of outlined that. And one of them was an Asian study, and it was they were looking at older Asian female cadavers, and so that they found that it was 19 millimeters, uh, which is actually very shocking to me.
Yeah, that's not far.
It's not very far, but again, I mean, just think about if you have a smaller head, everything's going to be in smaller dimension.
Yeah.
In my cadaver courses, I've measured 2 or 3 times It's actually fairly difficult to get to because you have to take off the coronoid process. You have to take off the zygomatic arch really to kind of get in there. So you really kind of got to actually do quite a bit of dissecting to get back there. But the time that I did, it was 33 millimeters from the tuberosity to the maxillary artery.
It's more like it. Yeah. I started getting nervous if I'm drilling. I mean, I think we're kind of similar. Like 95% of my pterygoids are 4x18. Probably. But if I start going a little bit deeper and I'm like going past like 22, 24, I'm like, okay, that's a bit too far for me. We're going to figure something else out.
Yeah. So, maybe just move your coronal entrance point a little more posterior, and then then your distance is definitely shorter.
You got it.
But back to the buccal fat, it has some mesenchymal cells, and so plus the blood flow, it really kind of helps to weather our buccalized zygomatics from having any type of recession. So
I'm curious, so we talked about how you're exposing it with the blunt dissection, you're using the beaver end of your number 9 to kind of tease everything out and help it sort of move forward. What do you actually use something to physically grab it and pull it forward? And what do you like to use if so?
On occasion, like I really want to make sure that once you pull, if it still is kind of not teased out, it then begins to tear.
Yeah, that's what I'm getting at. Yeah.
So I wait until I've got pretty good movement, and then I'll grab it pretty deep and then to kind of pull. And then, I wind up suturing that down. Sometimes, you can suture it to the anterior nasal spine. You can make some transosseous sutures if you wish.
Sure.
But it really requires, you need to make a basket weave with your suture. So sometimes we'll go through it and around it 5 or 6 times to really give it where we're pulling it anterior to position it from all within the buccal fat that we have teased out. So it's going to be pulled from the posterior, the middle, and the anterior portion, and that allows it not to tear and become thin.
Okay. Yeah, very good. Yeah, that's when I first started doing it at the cadaver lab. That's what I was kind of running into. Is I was getting a little bit too ahead of myself, and I'm trying to pull it, and I just tear it, and it gets thin, kind of useless.
Yep. Totally. So here's just a cool picture of just kind of how big it is, and all the different lobes. It goes under the zygomatic arch up into the where that temporal muscle is. You got the buccal extension. Again, we're not going to touch that. Let the plastic surgeons take that out on our influencers, and
It's for the buccectomies. Yeah, great.
So perfect.
Yeah, I was curious. Do you ever see any facial change at all? Because you're leaving that buccal lobe, I suppose. You ever see any type of narrowing?
No, just because everything's coming out of that fossa, right? And so the infratemporal fossa is bound by the zygomatic arch, the coronoid process, and medially, which is kind of that the lateral sphenoid wing.
Yeah. Okay.